But I thank you for raising that, Jason. It's both perhaps a charter as well as a bylaw as sort of an operational issue. Do we want to have perhaps just 2 subcommittees instead of 3, or re-chunk the subcommittee structure in, a different way?
My thought is that pragmatically we need to organize something for today so we can do the discussion, and I would propose that we have 2 subcommittees, that we have a research subcommittee and then another subcommittee that might define itself, so people that are less interested in research come together as a group, and for the purposes of today, perhaps the new members self-select.
Could you tell us who's on each committee now?
That's what I was just going to check. So of the remaining, of the older members, who of those left are on the research committee?
Len, Art, and Ron.
So that's 3.
And then the ex officios.
Yeah, the ex officios, 3. Education. Nancy. Okay.
Yeah. So Nancy's by herself on the education subcommittee and patient care quality of life. Jason, are you it?
Yes,
and
Chris,
and
myself.
We're not counting ex officios because it's not a quorum.
So my thought is that whoever was formerly on the quality of life would go with the non-research group at this point, unless they felt they were more appropriately housed in the
We should
research.
open that up for discussion, because obviously that committee in large part was sort of the mouth for the patient community. We don't want them to think that we're not interested in those issues, but we're sort of transitioning it into more of a broader second committee.
Well, I mean, one of the things that came out of our discussion in that committee was that so many of the quality of life issues impacted on research, they impacted on education, and so it was difficult to not be involved in those discussions as well. So I think that would just leave you to decide where you want to go. I can do what I like because I'm the chair.
And and from my perspective, education and quality of life can fit together with even within the subcommittee structure, with special recognition of patient or consumer needs for education, family, caregiver support, whatever, provider education, maybe policymakers, broader audiences for educational efforts. And maybe that's just the way I parse things out. Quality of life sort of threads through all of those, because if your care providers, whoever they are more informed about the natural history of chronic fatigue syndrome, and your policymakers are informed, the insurance companies, whoever, it seems to me all of those roll toward quality of life as well. So, and besides, I'm always sensitive to the fact in several other groups I'm in where it feels like the patients are always sitting somewhere else. And, I'd really like to see a little better, I think the opportunity is stronger for better integration, that we all keep conscious of, the focus here.
I didn't want to force a committee structure down anybody's throat. I think we need to come back and look at that in the bylaws. I'm just trying to get something pragmatic for today so that we can review the recommendations.
So as the only member of the Education Committee, I knew this was going to happen. And I talked to Rebecca, who was chairing the Quality of Life Committee before. In the past, we've morphed our committees together and shared some of the same recommendations. We put some language together. I think so long as in the end what we understand is that these working groups really do a lot of the work of this committee. I mean, this is where the real muscle of this committee has come together. As long as we're not dispersing too much by becoming too trying to do too much in one group, I think that we could well morph the two together.
And I don't see a problem within a larger committee that people being tasked to address a particular problem. So if there are 2 sides to the coin, then with a larger group you can self-select or assign people. So.
And we get the big room, and the research committee has to go down the hall.
Yeah, and the better food.
Yeah.
One of the things just
Mark had his hand up.
So Mark, and then Lenny.
Yes, I would like to say something about quality of life. I think my interest as the ex officio member from the FDA in the Quality of Life Committee is that quality of life also has a significance in research and clinical research and patient-reported outcomes. And clinical research in chronic fatigue syndrome is certainly an area that does make use of patient-reported outcome measures and so forth. The agency has taken interest in that, and a guidance was issued recently about patient-reported outcome tools and use for making marketing claims. But these also have implications, I think, for broader areas of research. So I think certainly the quality of life of the patient is certainly an important issue too, but also the aspect of that in research needs to be taken into consideration.
And I don't think there's anybody around this table who's not concerned about patient quality of life. Lenny.
Yeah, I just wanted to sort of reinforce and agree with what you said, that, this stuff all can't occur at this meeting. And I know at the research subcommittee, we actually have monthly meetings on the telephone that, Wanda and her office help facilitate. And I would strongly suggest that, each of these subcommittees meet on a monthly basis so that they can continue the work and really sort of think about the issues that need to occur. Because if we just get together twice a year, we're just not going to be able to accomplish as much or be as strategic. And again, that's the second issue of, I think Mike Miller has talked to me a number of times about the importance of strategic visions, and I'm wondering if, I'm putting him on the spot, I know, but he's got a lot more administrative experience than I do. What's the importance of being strategic, Mike? I'm wondering if you might just be willing to comment on that issue.
Just happen to have a few notes on that. Now, I really have nothing to formally say about strategic vision, except that that really should be one of the functions, in my view, of what our committee does, who can think ahead, think through the smoke, and be progressive in our thinking of what we can do. And I don't think we should put roadblocks or let roadblocks currently prevent us from thinking far ahead. We may be able to remove those roadblocks because we have the type of help now that can do that. But strategic thinking to me is looking at the big picture rather than looking down too far into the weeds of details. It's understanding what the secretary really needs in terms of a recommendation. What are the characteristics of a good recommendation? It's not just a wish. There are things much more to it in terms of public health outcome, and that's what the secretary, I think, is going to be looking for. So strategic thinking to me is exactly what all of this group sitting around this table, the wisdom here is what this patient population really is looking to for leadership and that type of thinking. So I have really no details on how to do that. I think you've all done strategic thinking as opposed to tactical activities. And that's what I'd like to see us focus on a lot of times.
No more questions? 15 minutes left before lunch. Is it worth addressing the charter, or do we want to take lunch a little earlier? Would it be appropriate to come back a little earlier, and then if we have some extra time, we could add some time to the public comments?
I'd suggest we try to start the discussion of the charter and then end on time. If we can save time, we can add to the public comment period. If we save 15 minutes, the trouble is we have people queued up for telephone. Gotcha. And my concern is if we start that way too early, we will interfere with folks when they expect it to be called. Even 15 minutes doesn't sound like a lot, but it could make a huge difference for